for inviting me. I have to say that I started with like a presentation that started with over an hour and I whittled it back. And so I know I have about 20 minutes. I've got my stopwatch going. So we're going to talk about palliative and end-of-life care in the older adults. And we're also going to kind of weave in the intersection of chronic illness and its effect on mental health. And I don't know why it's not advancing. Oh, here we go. So I'm Daphna Grossman, and my only financial relationship is with the D'Souza Institute. I do get paid for leading their workshops. I also get paid for being a content reviewer for them. This program has not received financial support other than the RBC Foundation. It has not received in-kind support, and I do not have any potential conflicts of interest. And if this is, obviously I'm going to mitigate any bias possible, but I don't have bias, and it's a CME program. Do I have to read this slide? Sorry, no, okay. Okay, so I'm sorry, my objectives. So I decided to focus down on 4 themes. One is, when do we integrate a palliative approach to care for the older adult living with chronic illness? What is our approach to attending to suffering for a person living with chronic illness? And what are the special nuances for patients with dementia? What are some approaches for advanced care planning and goals of care discussions? And also I'm going to weave in discussions about a request for hastened death. Now, Mr. S is a patient who I always present. He is an amalgamation of many of the patients I look after here at the hospital. I see patients in the clinic, I see patients at home. And he is going to have some changes in some of his medical issues as I weave in other issues that are relevant to the cases. So he's 88 years old. He has heart failure and kidney disease, diabetes for years. He has had progressive symptoms of depression worsening in the last year. He has spinal stenosis, which causes pain. He lives with his daughter and granddaughter. He's originally from Italy. He immigrated to Canada when his children were young with his young family, and he is very proud of what he has built and what he has accomplished. He is now a widower, and he lives with his granddaughter. So he has significant, like I've highlighted 4 significant issues. Pain is a big issue. He has spinal stenosis. He has neuropathic pain. It affects his mobility and it affects his sleep. He has heart failure and kidney disease. So he's tired. He gets short of breath. He has to sleep on several pillows. He wakes up in the middle of the night to go to the bathroom several times. In terms of his depression, in the last year, he's been felt more isolated. He participates less with family get-togethers, and at times his family have described that he said he doesn't want to eat because he wants to die, and he needs increasing help with his ADLs and IADLs. And I don't know about you and your experiences with folks that you take care of, but I hear a lot of times issues related to dignity. I'm a burden on my family. I was always the strong one. I was the one who everybody came to, and now I need help. I wish I could go to sleep and just not wake up. And these are issues that he expresses. Now, this is an older slide from Health Canada. I just really like it because it really shows us that as we get older, we are living with more and more chronic illnesses. And you can see that at 80, by 80, 37% have 4 chronic illnesses, 20% have 3, 21% have 2. Most of us are living with chronic illnesses. And this affects our mental health and wellness, because we also know that chronic medical conditions are significant risk factors for depression and mental health issues. So the question I always ask is, should we integrate a palliative approach to care? Normally I ask everybody, but everybody has always said yes. So that's why I don't make it a polling question anymore. And the reason is that, you know, it attends to quality of life. It attends to quality of death. It alleviates family stress and anxiety. It offers an extra layer of support. It increases satisfaction of care. It does all these fabulous things. And yet there is so much resistance to applying a palliative approach to care. And I hear this all the time. The person isn't palliative yet, you know, he's not dying yet. If you say the word palliative, everybody thinks that he's dying. You know, he's got a chronic illness. So where would I put in palliative care? And these are all really good questions. I wish palliative care, the term didn't have so much stigma, and that's why we now call it palliative and end-of-life care. So what I'd like to do is present a very concrete approach on knowing when to integrate a palliative approach to care. And this is one of my favorite prognosis. Okay, so how do we think through it? Does the person you're looking after have a progressive incurable illness? The answer is yes. You ask yourself, would I be surprised if this person died in the next 1 to 2 years? Used to be in the next year, but kind of it's decided that really, if you look at the next 1 to 2 years. And if the answer is no, I really wouldn't be surprised, or yeah, maybe, then really we should think about a palliative approach to care, which I'm going to talk about in more detail later. The next thing is, does the patient have indicators of decline? Are you seeing an increasing need for support? Are you seeing a more complex symptom burden with decreased reversibility and decreased response to treatment? Does the person say, I want more of a symptom-focused care? Are you seeing progressive weight loss? Are you seeing unplanned crisis admissions? Has there been some kind of sentinel event? And are you seeing lowered proteins or albumins? And one of the things that I love about this framework is that when you are talking to families, and later on we'll talk about, you know, the goals of care conversations, these are words that you can use. You know, when I see your dad, I worry that he's got worsening symptoms, that it's becoming more difficult to address the symptoms without causing other symptoms. So I really like this because it offers the terminology, and it has been shown in the literature to help with communication. So are there indicators of decline? If the answer is yes, a palliative approach to care. And then you can look at the specific indicators of decline, which I also find are very helpful to talk to patients or residents of long-term care families about, because it looks at the different disease complexes. Like, is it heart disease? Is it dementia? Is it liver disease? Is it kidney disease? And it talks about those specific indicators that show that the person is entering a phase where there's going to be more complex care issues. So does the patient have specific indicators of decline? If the answer is yes, it's a palliative approach to care. If the answer is no, you keep reassessing. Now, in Scotland, they took that whole concept and put it into this nice one-pager called a SPICT tool. And I find that this is very helpful, like if you have your charts, if you have an EMR, as a communication tool with patients and families to show them what it is that you're concerned and worried about. And it's a wonderful trigger tool to remind yourself that it's time to integrate a palliative approach to care. So this is a slide by my friend and colleague, Julia Perry. It's a brilliant slide, so I love using it. And this is the framework we are going to work through when we talk about a palliative approach to care. You look at what are the burden of symptoms, and we're going to talk about how to do that. What is the level of functionality, and what are the goals and wishes? And all three together are going to feed into what investigations and treatments should we be pursuing, what is reversible and what is no longer reversible, what non-pharmacological approaches we could use, and what pharmacological approaches we can use. Because we recognize that symptoms and illness burden, limiting mobility, also contribute to depression. So when we are looking after our older adults with symptoms of depression and anxiety, it is important to also assess these issues as related to their medical conditions. And we also know that addressing goals of care reduces anxiety for patients and for caregivers. So this is a very important framework. So let's start with symptom burden. The Edmonton Symptom Assessment Scale is a great jump off to look at symptoms associated with chronic medical illnesses. And I would encourage that we do that also for patients that we see for older adults with chronic illnesses that we may be seeing for mental health issues, because chances are their chronic medical issues are also contributing. And so the way it works is you ask the person from 0 to 10, where 10 is the worst symptoms, 0 are no symptoms. How bad is your pain, your tiredness, your nausea, how lousy is your appetite? And you work down all the symptoms because it gives a nice framework of issues that are a physical burden. And it also asks about anxiety and depression. At the bottom, you'll notice that you can add any symptom you want. I do constipation, I do sleep, it could be itchiness, it could be hiccups, it could be nightmares. It's whatever it is that you want to assess how severe it is on a scale so that you know how your interventions are helping. So for Mr. S, we know that he's got pain, he's tired, he's short of breath, he's anxious, and he's not sleeping well. You always ideally, you want the person to complete their own form. However, you might need to help them, or for someone who's got cognitive impairment, it might be the caregiver, as long as it's the same caregiver. For pain in the setting of dementia, I would suggest you use Adult FACES scale or the PAINAD scale, which is the pain assessment in advanced dementia, which is also from 0 to 10 and a wonderful way of assessing pain. It is so important because pain can be a contributor to behavioral symptoms that we see associated with dementia. Pain can be associated with depression. So it's important to address those issues. The next issue is the Palliative Performance Scale. And this scale that we use is disease agnostic. And it relates to the clinical frailty scale. It relates to the ECOG that we use in oncology. The truth is, any scale that assesses functionality, the PPS is going to relate to in some way. The way it works is it's based on 5 features: how well you're walking, what your activity is, how much you can take care of yourself, what your oral intake is, and your level of consciousness. You start to the left and you move across to the right. So if you're still able to walk like full, no walking aids, you're in 80%, as long as your intake is normal and your level of consciousness is normal. It could be slightly reduced. Once you hit a Palliative Performance Scale of 60%, that's somebody who has who's moving to a critical frailty scale of 5, where you're now walking with a walker, you need more support. At 30%, it's somebody who's always in bed, and typically their intake is reduced. Typically they might be more drowsy. And then 0 would be death. Why is this important? Because we know as we go down the scale, we're getting closer and closer to dying. So I find the scale really helpful because, as we all know, determining prognosis is impossible. There are these wonderful different prognostic calculators and scales. And the truth is they're invariably incorrect because it's based on the law of averages. But how do I use the PPS? Your change of number or level over time is, I find, the most helpful in prognosticating. So if somebody that you meet is a 60% and 2 years later they're a 50%, their disease is progressing very slowly, and you can count their trajectory of illness in terms of years. If somebody who I meet who is now in bed 30%, but they tell me that 6 months ago they were at 60%, and 4 months ago they were at 50%, and 3 months ago they were at 40%. Now I'm seeing them at 30. I know that their trajectory of illness is in weeks to months. So it's that change, that rate of change over time, that is going to be so helpful in how you share the information. In dementia, I find it's the most helpful to take out the middle 2 columns, because self-care and evidence of disease is an early, it happens early. So in terms of how the progression towards dying is based on ambulation, is based on intake, and is based on level of consciousness. So that's how I tend to use it for patients with dementia. The distress thermometer is something I like to use actually for the caregivers that I work with, because also to give an idea, many of the caregivers also have their own medical issues and also have significant caregiver distress. I know there are caregiver distress measurement tools for folks with dementia. This is just a very simple one to use, so I find it very helpful. So I'd like to now bring it to Mr. S, who didn't have dementia before, but now has dementia, and he has episodes of agitation. And what's the approach to this? Well, again, we're going to go back to that framework. What is the burden of symptoms? So his symptoms might be more moderate, like an agitation might be 4 or 5. What is his level of functionality? Well, it's 70%. So his mobility is reduced, but he's still able to eat and he's still fully conscious. The goals of care we're going to get to soon. So the reason this is important is because as we discuss goals of care, as we discuss trade-offs of how we're going to manage symptoms, it's going to make a difference, one, on how severe the symptoms are and what level performance scale Mr. Smith is. Because with Mr. Smith now going down to a palliative performance scale of 30, the issues now will also be different. And at 30, we're also going to be talking about issues with nutrition, hydration, because his intake will be reduced. And this is where we get to goals of care discussions. And this is the nationwide campaign, the Speak Up campaign. And the important thing is we're exploring illness understanding, values, people's worries and fears, what their trade-offs are and what their wishes are for end-of-life care. The problem is, and I don't know if you find this in your practice, I find this in my practice, is often with our patients with dementia who no longer can speak for themselves, the family didn't typically have the conversation early. A few of them did, but many of them often say, I don't know what they would have wanted or what my parent would have wanted, and are often still using very aggressive therapy at end of life. Now, I'm including this slide for you because this was a cross-Toronto tool, and it was developed by a group of emerge physicians, palliative care physicians, internists, ICU caregivers, and what it did was it took the language that is being taught through Vital Talks and Ariadne Lab. So those are two big companies that have really focused on teaching how to have very good serious illness and goals of care discussions. Ariadne is who put together the Serious Illness Conversation Guide. You can just Google that, and it gives you a template of discussions that was of what to say. And the whole idea is you're actually supposed to read what was said because that's how it was developed. And we use this to build a template to explore goals of care with a patient and their families. I find it very helpful. I bring it into all my meetings, and you first explore illness understanding. You ask permission for discussions. We talk about goals and values, and then we talk about, based on what you shared with us, these are our recommendations. And it has examples on the left of how to ask the questions. So I find this tool very helpful. So the big issue, or the main issue, is in terms of that risk and benefit. Where we always struggle is, especially in terms of using medications in our older adult, when we are treating pain, when we're treating shortness of breath, we're teaching agitation and delirium, because all those medications have significant risks, whether it's a risk of fall or confusion, the black box warnings associated with antipsychotics and sedation. And the thing is this is where those goals of care discussions are so important, because it's how we assess our trade-offs of risks versus benefits, meaning what are you willing to risk for decreased pain? What about for decreased agitation? what is good enough decreased pain? What is good enough decreased agitation? That's where that ESAS comes in. What would be quality of life and quality of dying for you? So Mr. S, and this is actually a gentleman, my Mr. S, who I took care of 2 weeks ago. His hallucinations and agitations were quite severe, and so severe that the family was very clear that their dad would not want to be awake and agitated. For them, it would be a better quality of life for him to be sleeping than to have any agitation or any hallucinations, even if sleeping meant that he wasn't able to eat and drink. And which is what we ended up doing. We ended up titrating his medications until his agitation and his hallucinations were gone. And at that point, he was sleeping, because that was what was important to them. And as part of end-of-life care, it's also very important to remember that you want to use subcutaneous provisions of medication, not intramuscular. You want to have good mouth care. I always have medications for congestions. We use antipsychotics for symptoms such as nausea, vomiting, agitation, and delirium, and methyltrimeprazine being a more sedating one that can be given subcutaneous, and of course anxiolytics, which are typically adjuvants to the antipsychotics and adjuvants to the opioids for pain and shortness of breath. And of course, preparing the family for end-of-life care, preparing the family of what they're going to see at end of life. I do want to talk for a minute about the desire for hastened death. Talking about desire for hastened death and medical assistance of dying is a big conversation in itself. I do feel that this is also part of palliative and end-of-life care, because there are patients who do wish, despite optimal palliative care, to continue and receive medical assistance in dying. But what's important is how to address the question, or how to address the request for medical assistance in dying. I really love Monica Brannigan's article, which is why I'm including it here. But the important issue is you want to really address what is the suffering, and really explore what suffering can be alleviated, because it always comes down to, is your suffering alleviated enough? Is your request for hastened death a expression of how frustrated you are? Is it an expression of your loss of dignity, sort of like Mr. S before? Or, as in some of my patients, despite all the optimal interventions, they do continue to go on to request medical assistance in dying. What's important to know is that it is not is necessarily associated with depression, as 50% of those who request for hastened death are not depressed. And what's also important to know is that there has been a change in the medical assistance in dying laws, which I'm not going to go over, but I am including here for you to see, as there are two distinct tracks right now, where death is reasonably foreseeable, where you can sign a waiver, so you do not have to be able to consent at the time of the procedure, or where death is not reasonably foreseeable, which is now is something that comes to light, especially for Mr. S, where he may have heart failure, where death may not be reasonably foreseeable, but he is now allowed to request medical assistance in dying with a 90-day reflection period. But again, it is something, I often see it kind of as a checklist. Do you want palliative care, or do you want medical assistance in dying? And what I'd like to really stress, that it is a real exploration of suffering when someone requests medical assistance in dying. Okay, I see I'm at 24 minutes, so I'm going to finish by saying this. This was a murder trial. I don't know if you saw this in 2019, happened in Quebec and happened in a long-term care home. And I end my talks with this, because this is a a story of a husband who murdered his wife in a long-term care home because he felt she was suffering so much, and he could not see her suffering. He was convicted of murder. But what struck me was the line that said, if we foresaw an imminent death, that we would have added the therapeutic treatment of palliative care patients, like opioids to manage pain and drugs to help breathing. But for her, we hadn't got to the point. And this really strikes me, because if she was in long-term care with severe symptoms, even if she wasn't in long-term care with severe symptoms, they got to the point where palliative care should have been introduced. So in summary, a palliative approach to care is to attend to suffering, physical, psychological, spiritual, and social, understanding the burden of illness, treating symptoms, discussing disease trajectory, managing care and preferred location of care, and prepare for healthcare decisions. And the truth is, I just like to stress, it's just good care. Thank you.